Dear colleagues, it is a pleasure to join you today from Vancouver. I regret that I cannot be in Thailand for the workshop on antiretroviral therapy access in people who use intravenous drugs. However, I am grateful for the fact that I've been allowed to put my presentation together for you today in a video format. I hope that this may be helpful to you in your discussions. I would like to specifically share with you our experience regarding the use of treatment as prevention, that is prevention of morbidity, of mortality, and HIV transmission as the key to eliminate HIV and AIDS, with a focus on the experience that we have accumulated around this particular issue among injection drug users. My conflict of interest disclosure is as shown in this slide, as is required by the University of British Colombia, and my conflict of interest management and mitigation strategy is as presented in here. I generally don't believe that my funding sources or research funding play a significant role on the issues that I'm going to address here during this presentation. I would like to start by showing in this first slide what was the situation with regards to trends in annual rates of death for AIDS in North America for males aged 25 to 44 during the first stages of the epidemic. As you can see on the red line, between the early 80s and the early 90s, that red line was going up rather furiously, and we were having very serious doubts that there would be a strategy that would allow us to turn this trajectory down. Little did we know that research that we had started in collaboration with our good friend Joep Lange from the Netherlands, David Cooper from Sydney, Stefano Vella from Italy a few years before, will ultimately open the door for a potential solution. That was the INCAS trial that for the first time demonstrated that triple therapy containing nevirapine, ACT, and DDI given to HIV-infected antiretroviral therapy naive individuals could lead to full suppression of viral replication. At the same time, the Merck 035 study led by Trip Gulick mature, showing that indinavir-based triple therapy with ACT and 3TC could also lead to suppression of virus in a sustainable fashion. These data emerge together with a new set of guidelines that was put together under Carpenter et al. At JAMA under the auspices of the International AIDS Society USA at the Vancouver Conference in 1996, and the rest is history. As you can see here, having introduced HART in 1996, the death rate on the yellow declined very quickly in the province of British Columbia thereafter, and life expectancy increased steadily also after 1996. Today, my good friend and collaborator, Dr. Bob Hogg, has estimated that a 20-year-old person infected with HIV who starts treatment in a sustainable fashion with high adherence on a long-term basis is expected to have a near normal quality of life for a near normal longevity approaching the age of 75 years old. This is a remarkable change in outcome, all as a result of highly active antiretroviral therapy. While we were rolling out antiretroviral therapy following the 1996 conference, we saw something that we were not anticipating. As illustrated here, HIV rates started to decline despite the fact that syphilis rates were going up and up and up. It was as a result of this observation that we came out with the notion that antiretroviral therapy being used in the community to prevent morbidity and mortality was being associated with an unexpected and rather profound impact on HIV effectiveness. It took a fair bit of work to nail this issue down, but eventually we did. And really, we did so primarily looking at our experience in our cohorts of injection drug users. I'll refer to that more in a moment. What we eventually postulated, as published in The Lancet in 2006 and presented at the Toronto International AIDS Conference, was that there was a very strong case for us to propose the expansion of access to highly active antiretroviral therapy to curb the growth of the HIV epidemic, with regards to morbidity, mortality, and secondarily transmission. We basically postulated that highly active antiretroviral therapy stops HIV replication. As a result, the viral load falls to undetectable levels in the blood. With that, we have a corollary of a recovery of the immune system, and the disease basically enters into remission. In addition, there is a suppression of the viral load in biological fluids other than blood, including semen, cervicovaginal fluid, rectal mucosa, etc. And as a result, we postulated that less virus would be associated with less infectivity. The sharp reduction in HIV transmission associated with the use of highly active antiretroviral therapy was estimated in the order of 90% based on our ecological studies. Eventually, this was confirmed by HPTO 052, which I will refer to later. We had the opportunity to monitor the rollout of highly active antiretroviral therapy in the province of British Columbia now for a couple of decades. I have color-coded this in my slide to give you a sense of what's been happening. You see the phase 0, the pre-HART phase on the red color. This is when we had only very few individuals, selected individuals, typically asymptomatic individuals, being treated with highly active antiretroviral therapy as part of the original clinical trial, the INCAS trial. Since we became aware of the benefit of the treatment early on, our program really kicked off before the conference in 1996. By the summer of 1996, we were well on our way to enroll people into this program. And interestingly enough, the Vancouver 1996 conference became the massive knowledge translation event that allowed for a very brisk uptake of triple therapy in that phase 1 that I illustrate in the yellow zone. The yellow panel, as you can see here, is divided in the middle at the beginning of the year 2000, at that point when we reached a saturation of antiretroviral therapy use in the population with an indication for treatment at that time. And that's basically the steady state phase that continues until the year 2003. This phase was characterized by people taking treatment interruptions or delaying initiation of treatment based on the fact that the earlier treatments were not necessarily a curative solution. They had complexities, multiple pills, multiple doses, side effects, and therefore significant chances of development of resistance. As we approached the mid-2000s, newer drugs became available, namely tenofovir in particular. This was a safer and a better tolerated alternative to deoxynucleosides. We also had new evidence, particularly from the SMART trial, that earlier treatment was desirable and treatment interruptions were strongly advised against. And so all of these, plus the emerging evidence that treatment could prevent not only morbidity and mortality but also transmission, allow us to enter into a new phase where HART was not only available, as in the yellow section here, but rather where treatment was actually encouraged and increasingly being brought, or the services, test and treat, were being brought closer to the people in a facilitated fashion. And this is basically what we call the treatment as prevention era, which increasingly is characterized by us making greater and greater efforts to engage the most at-risk populations and more vulnerable populations in early access to both the test and the treat component of the strategy. This has continued ever since, and really the slope of this curve continues to increase as of today. So, given the comprehensive monitoring of the epidemic we have available in the province of British Columbia through our center, we have been able to characterize the full natural history of the epidemic in BC. So similar to what I showed you in the first slide, in this case I'm showing you new AIDS cases diagnosed by year in the province of British Columbia starting in the early 80s. And what you see is that the first cases appear in the early 80s, they peak in the early 90s, they slow down a little bit around 94 when we have dual therapy having some impact, in terms of disease progression, but really things don't improve significantly until the year after the year 1995, when triple therapy becomes available. It's interesting to note that with the availability of HAART in the yellow panel, we were able to decrease the number of new AIDS diagnoses, but the level at which we decreased the AIDS diagnosis remained steady in the 200 cases per year. It wasn't until we embraced treatment as prevention that new AIDS cases actually declined significantly to somewhere around 50 cases per year. I actually use this slide to make the point that the availability of HAART at the populational level was not sufficient to have a maximal impact on lay presenters and therefore continued AIDS morbidity. It wasn't only with the ability with the availability of treatment and prevention. It wasn't until the point that we brought the services to the people, we got greater penetration in our community, that we saw that morbidity actually took a nosedive. And this actually is even more dramatically observed when we looked at mortality in this setting. During the HAART era, mortality dropped significantly from just above 350 deaths per year in 1996 to somewhere around 75 deaths per year in 2003. A very significant improvement, but yet still a fairly high number of deaths per year, avoidable deaths, I might say. It wasn't until we truly engaged on treatment of prevention that we see finally, after 2009, that the number of deaths have gone down remarkably, so that today we have more than 90% decrease in morbidity or AIDS morbidity, and more than 90% decrease in AIDS mortality in the province of British Columbia as a whole, as a result of the implementation of the treatment of prevention program. I think it's graphic to illustrate this by showing you some of the paper clips from recent days. This is from our local newspaper, May 31st of this year, where they celebrate what they call the AIDS war closing in the province. There was one war that was designated as the AIDS war at St. Paul's Hospital, our hospital, and this has now been repurposed and expanded to include priority access for people infected with HIV with medical conditions, for people affected with hepatitis C related problems, or for people affected with injection drug use related problems, all areas where we have developed a significant expertise as a result of our extensive work with the AIDS population until now. The reality is that we have basically reprofiled the use of the word to address what the census of the word has been telling us over the last several years. We're happy to see that we're moving forward, still serving our HIV-infected population, but basically being able to make the statement that AIDS is no longer a significant concern. The other thing that it hasn't been celebrated sufficiently, in my opinion, is the fact that by implementing treatment of prevention, without additional programmatic interventions, we have had a major impact on the transmission of HIV from mother to child, the vertical transmission of HIV. This slide, complex as it may sound, illustrates about 300 pregnancies among HIV-infected women in about a decade. I'm happy to report that there have been no further HIV infected children born even since 2012. But in any case, over this decade, you see two red arrows here. Those represent the two only children that were born with HIV infection during this decade, 2 out of 300 pregnancies. In both cases, those two children were born in situations where the diagnosis of HIV was not made until the mother was in labor for socio-economical, cultural reasons. Unfortunately, we still have issues in that regard. But having said that, these represent 2 cases out of 300, suggesting that we're approaching the virtual elimination of vertical transmission of HIV. From the bigger, sort of broader province-wide perspective, if we now look at HIV new diagnosis, you will see that on the yellow chart, on the red line, with the availability of HAART, we had close to about a 40% decrease in new HIV diagnoses. And there was an additional 30% or so decrease in the number of new HIV diagnoses with the implementation of the treatment of prevention modality. Interestingly, despite the fact that when we launched this effort, we were warned that IDUs or ever IDUs would be the most dangerous population to engage with because the propensity to have incomplete adherence and therefore problems with resistance and incomplete responses to the treatment, etc. We have seen that a comprehensive approach to the problem of the IDUs has allowed us to see the greatest response with regards to the decrease in HIV new diagnosis in this community. You see here that on the purple, new HIV diagnosis among IDU has decreased by greater than 90%, something that we're extremely pleased with. To a large extent, this is a reflection of the synergies between our very programmatic focus, but also our harm reduction programs, and I'll refer to that more in a moment. Sadly, the rest of Canada has not been paying attention to this approach, and so as you see in this slide, the simple availability of HART programs, which are available in the whole of the country, do not suffice to have the public health impact that we're hoping for. So HART is available everywhere in the country, but the only jurisdiction where HART is fully available for free without any co-payment or deductible or any medical expenses related to it, whether it's genotypes or laboratory monitoring, etc., is in the province of British Columbia. Other provinces have such elements that act as detractors in the ability of people, particularly asymptomatic individuals, to engage fruitfully on a long-term basis on a program of this nature. The other thing is that BC is the only jurisdiction that has a program that is focused exclusively on accessing individuals infected with HIV or individuals at risk, and therefore that focus makes it that there is some sort of an obsessive behavior on our part of trying to engage this population. In other jurisdictions across Canada, HIV is the domain of the general infectious disease practitioner, and so necessarily what happens is that people are served in as much as they are able to access the services, and that active component or engagement of the program in the seek and test and treat and retain element of the spectrum of engagement in care is not necessarily emphasized. That creates a problem because the practitioners are necessarily going to be distracted by other priorities that come their way, and as such we had the situations like Saskatchewan where you see a very rapidly emerging epidemic, Manitoba the same. Again, I believe that this is something that could be corrected if we had a treatment of prevention initiative and a focused program dedicated on the control of HIV. And this is not a trivial matter. Bob Hogg, again, has looked at the savings from averted HIV cases by region in our country. He has come to the conclusion that British Columbia, and the top and the blue, is basically laughing all the way to the bank. On the other hand, on the green, Saskatchewan is actually mortgaging its AIDS future because of the lack of action in the short term. So these are two very contrasting scenarios, and we are making the case that a slightly greater investment up front allows us to address this AIDS mortgage, and as British Columbia has done, incur in a favorable situation where we not only we save lives, we save new infections, but we save money. As far as the continual and ongoing progress of the program is concerned, I strongly recommend that we focus our attention in monitoring carefully what the engagement in care is for individuals infected with HIV. And for that, the cascade of care, as proposed by Gardner some time ago with Carlos Del Rio and a number of others, has proven to be very valuable. We actually embraced this approach a number of years ago, and we have been using this to monitor and evaluate our program on an ongoing basis. what you see here is work that my colleague Boran Nosik has done to characterize the evolution of the cascade of care longitudinally in BC, characterizing in the red number of people diagnosed, on the blue the number of people linked, on the orange those retained, on the dark blue those on anti-retroviral therapy, on the yellow those adherent, and on the purple those suppressed. If you look across the years, you see that our cascade in 1996 was relatively underperforming. Things have gotten much better by 2011, and they continue to improve until today. And you see that the improvement is actually across the spectrum. So every single step of the cascade of care is improving. This is useful because it allows us to get into the cascade and look at groups of interest by either risk factors or geographical distribution or age or whatever. And we now know that there are huge heterogeneities in our cascade of care. For example, we know that youth is underperforming. We know that certain geographical areas are underperforming, typically the more disadvantaged areas, poor areas. We know that First Nations individuals or Aboriginal Canadians are underperforming with regards to the cascade of care. And we also have evidence that injection drug users are doing not quite as well as the non-IDU population. Now, having said that, I am reassured that the resistance concerns that were generated in some of the theoretical papers, particularly coming from California, have not materialized. As you can see here, the light blue at the bottom shows that the majority of our patients are suppressed. On the red, we have people that are not suppressed and that are wild type, and then the resistance portion of the population infected with HIV on a year-by-year basis is actually becoming smaller and smaller all the time. And in particular, we're very gratified that the highly resistant virus is virtually disappearing from the province. I believe that this is a function of a couple of elements. First, the focused nature of the program. Second, the fact that we have much better, simpler, more effective, better tolerated regimens that allow us to treat people more effectively. And if there is resistance, we have second generation and third generation regimens that allow us to deal with it effectively. So as for the resistance concern, this hasn't materialized. We have looked at this recently in a meta-analysis looking at the interaction between injection drug use and resistance emergence. Dan Ward from our group led this work published in Lancet Infectious Diseases in 2010. And what you see here is that although the different studies show slightly different estimates when you compare IDUs from non-IDUs when it comes to resistance, for the most part, the confidence intervals are all crossing the value of 1. So much so that the combined effect is 1.04 with confidence intervals of 0.74 to 1.45, altogether suggesting that resistance is not a key characteristic of treatment among IDUs. I thought I'll extend the discussion a little bit longer and use some of the work that Richard Harrigan in our group has done to try to further illustrate this issue. The first thing to notice here is that when we did a multivariate hazard ratio for the emergence of resistance on the vertical axis against prescription refill compliance as a percent in the horizontal axis, we find that the relationship between these two variables doesn't follow a typical Bell distribution. In actual fact, it's skewed significantly towards high adherence. In other words, it takes a great deal of effort in terms of taking the medications to actually have persistent resistance in the blood. These peaks are around 85% adherence. If we now take this to the next level and take the most adherent patients and discretely separate them based on blood levels of the drugs into those that have consistently detectable drug levels, consistently undetectable blood levels, and those that have intermediate patterns of drug being measured in the blood, you find that those that have high adherence by refill compliance, but they have consistently non-detectable drug in the blood are the ones that have the highest level of resistance, and those that have the blood, the samples consistently showing drug are the ones that have the lesser level of resistance. What this is trying to illustrate for you is that it's likely that among people who have disorganized lifestyles for a variety of reasons, and injection drug use could be one of many, mental health, poverty, other issues, the risk for resistance is actually shifting in such a way that unless they are able to be relatively highly adherent, they may not benefit from the treatment, but they're similarly not likely to harbor persistent resistance in the blood. If I were to put it in a different way, it takes a great deal of effort in terms of taking the medications, less than perfect, but not trivial, to actually develop resistance and maintain that in the blood on a consistent basis. And I think that that's a biosafety mechanism that happened to be there and has protected us from emergence of resistance in some of the more difficult patients in our community. As we evaluate these issues further, we have found that there are better ways of doing this, and these results are totally preliminary, and I'm not prepared to make a recommendation regarding this. But on a NIDA-sponsored trial that we're currently doing, we are looking at modest financial incentives to improve engagement of drug users in HIV testing, and then follow up and eventually achieving undetectability. In a very early cutoff for simply engagement on HIV testing, we have found that with the use of incentives, very modest incentives, we can increase the engagement of the participants in the testing algorithm dramatically, from 11% to 83%. Again, not yet ready for prime time, but if these results are verified independently, I think this would represent a very attractive proposition going forward. As I indicated earlier, if there was any controversy related to the value of treatment in terms of preventing transmission, this has been fully addressed by the HPT and 052, where it has been shown that immediate use of anti-retroviral therapy was associated with a 96% decrease of HIV transmission on a randomized controlled clinical trial. We have been fortunate to have the very strong support of Michelle Sidibe, the Executive Director of UNAIDS, in terms of pushing the agenda forward and trying to make treatment and prevention a cornerstone of the global control program. Eventually, President Obama jumped on board in December of 2011, starting to talk about the beginning of the end of AIDS. And of course, President Clinton has been a champion of this strategy, probably one of the first to advocate for our implementation of treatment and prevention at the global basis. All of that has opened the door for our group to work with the United Nations AIDS program to develop what we call currently a post-2015 Millennium Development Goal for antiretroviral therapy. And this new target basically calls for, by 2020, achieving at least 90% of people living with HIV to be diagnosed, at least 90% of them being on antiretroviral therapy, and at least 90% of them being virologically suppressed on a sustainable basis. If we're able to achieve this, the result would be that 73% of those living with HIV, at least 73%, would have an undetectable viral load, which would represent a threefold more than what we have currently as we approach the 2015 Millennium Development Goal of 15 million people on antiretroviral therapy by the end of December of 2015. We believe that in doing so, at least our mathematical modeling suggests, we could decrease the burden of disease by greater than 90%. In fact, we say that this strategy would maximize the effectiveness of existing tools by 2020 to virtually eliminate progression to AIDS, premature death, and HIV transmission, and thereby transform the HIV and AIDS pandemic into a low-level sporadic endemic by 2030. when we talk about virtual elimination of HIV and AIDS, we're basically saying that we should be able to reach levels that are 90% less than they were globally in 2010. In other words, reaching the 90-90-90 by 2020 will prevent about 20 million deaths and 30 million new infections by 2030, which would dramatically change the course of this epidemic. We do recognize that the 90-90-90 represents an ambitious treatment target. However, this is, in our mind, the only and the best way to write the final chapter of the AIDS pandemic. We know that this can be achieved because we have found examples of countries, programs, jurisdictions that have been able to approach the 90% diagnosed or 90% on treatment or 90% biologically suppressed. In other words, they're getting closer to the target in one of these domains. And so we believe that from here to 2020, if we learn from each other, we should be able to implement best practices so that we can optimize our ability to reach not just one of the 90s, but all three together, and therefore open the door for the global control of HIV and AIDS. We had the pleasure, the privilege of being at the United Nations General Assembly on September 25th, when the Secretary General of the United Nations formally endorsed and brought to the floor the 90-90-90 target as the formal proposal from the UN for a post-2015 Millennium Development Goal. And we hope that with your support and the support of the international community, we can ratify this at the next United Nations General Assembly so that from here until 2020, we can work together to achieve the 90-90-90 target. Some time ago, the question was raised by the economists in this case, whether or not we are in a position to begin talking about the end of AIDS. Now, of course, it's a matter of semantics and how you define that, but I believe that the 90-90 target truly represents the opening of the door of a new question, and the question is whether or not we can, working together, end both HIV and AIDS as a pandemic and transform this into a sporadic epidemic as UNAIDS has proposed. I look forward to working with you to achieve this goal. Thank you.